2.
Hello everyone, my name is Nyoka and this is my Change Project presentation. We'll be talking about post-operative pain and the management of pain with non-pharmacological pain management interventions. As we assess the population of ambulatory surgery centers and the post-operative pain mechanisms, we see that there is an excessive use of narcotic medications that are used as a first-line defense of pain. Excessive use of these narcotics for post-op pain can create dependence over time. Also, it weakens the receptors, causing higher doses to be administered to our patients. Patients who receive narcotics for post-operative pain, a lot of the times we will see negative effects from the narcotics being administered. So we'll see a delay in discharge times. You'll see negative effects on their vital signs such as decrease in heart rate, blood pressure, and decrease in respirations. Also, it can prolong their recovery time and allows for a harder time for patient instructions to be taught to them as far as discharge instructions. Patient and staff teaching, noticing on our units, we don't mention a lot of non-pharmacological pain relief measures for our patients, and we use narcotics as a first-line defense for pain. So our research question: in ambulatory surgery centers, how does non-pharmacological interventions compared to pharmacological interventions affect post-operative pain within the PACP period? Okay, the goal of our Change Project is to reduce the amount of narcotics being administered to our post-operative patients, and also looking into alternative measures to reduce pain without as many side effects and for longer lasting pain relief. Patients and PACU staff should be educated on how to incorporate these measures into post-operative pain relief, and as far as what measures will be best per patient and what to expect from the pain relief measures. As far as our literature review for our project, there's a few nursing articles that I did refer to. We see that treatment starts with assessment of the pain, and that pain is subjective to what the patient says and what they're experiencing. Also, we see that the use of multiple pain assessments can be more beneficial, so we can have more information on the patient's pain. Before we begin education of our nursing staff, we must make sure that we assess their knowledge of pain management assessment tools and their knowledge of non-pharmacological pain relief measures. Staff education should also incorporate different types of pain assessments. This could be including the analog scale, Minkowski scale, and also as well as the NSR pain scale. It's important that we incorporate these different types of assessments so we can look at various ways to assess pain and not just verbal accounts of pain, but also looking at physical manifestations of pain. It is also important to assess what the patient perceives as pain, their tolerable pain level, and what is intolerable for them, as well as what methods they're willing to try to incorporate into their everyday routine to alleviate pain. When teaching pain management for outpatient surgery, we must look at both acute and long-term methods to achieve pain relief. While pharmacological measures may be beneficial initially, they can cause disorientation to mental status, physical instability, and negative effects on vital signs. This in return prolongs patient recovery time and delays patient discharge. Excessive use of narcotics for post-operative pain can create dependence over time and weakens the receptors, causing higher dosages to be administered. The goal of non-pharmacological interventions are to decrease fear, distress, and anxiety, and to reduce pain and provide patients with a sense of control. Non-pharmacological pain relief measures can include repositioning, ice therapy, music therapy, heat therapy, relaxation, and meditation. Methods can be used long-term by patients and during the post-operative period. Providing patient education preoperatively about post-operative pain can help reduce stress and anxiety. When discussing pain management options with patients, be sure to discuss what is expected from the treatment and the treatment meets their expectation of what the patient wants for pain relief during the post-operative period. Patients can be provided pamphlets or discharge instructions explaining pain relief measures that they can implement at home. As discussed previously about implementing non-pharmacological pain relief measures, first we start with a pain assessment to determine what the patient wants from pain relief and what measures they're willing to try. We must figure out the type of pain they're having, whether it's aching pain, dull pain, radiating pain, to figure out which pain relief method will be best for them. There's a few types of different methods we can use for pain relief. The first being musical therapy. It has the power to soothe, inspire, and energize and uplift. Musical therapy is beginning to be implemented in surgery centers across America. Music therapy can promote relaxation, deep breathing, and rest. It also relieves stress and anxiety and can have a positive mood boost. Next, we have cold therapy and heat therapy. Cold therapy relieves pain and promotes decrease in edema caused by vasoconstriction. It also suppresses inflammatory reactions and decreases muscle spasms and contractions. Heat therapy does the opposite by promoting vasodilation and relieves muscle spasms and rigidity. Heat therapy should be used with caution after surgery. It should be avoided within the first 24 hours. Meditation can be used as a distractor of pain by asking individuals to focus on his or her own breathing, visualizing on an object, and focusing their thoughts elsewhere. Attention is directed on something else instead of pain, and it allows for anxiety reduction and relaxation of the individual. Relaxation techniques can provide relief for postoperative pain by providing relief from mental and physical stress, by relieving anxiety and related muscle tension, and thus also acting on muscle spasms that are caused by surgical interventions. Lastly, we'll talk about repositioning. Staying in the bed for a long period of time in the same position causes patient pressure and discomfort and pain. Position changes can reduce the pressure in the painful areas, increase blood circulation, and prevents muscle contractions, and it helps prevent pain and increase patient comfort. Once the plan is in motion and we have educated our staff and we've incorporated using non-pharmacological pain relief measures on the post-operative unit, we can establish a means for evaluation. As far as the educational evaluation, we can do weekly checks for our PACU staff, and we can use discussion and provide updates for any new information that we have gathered throughout the following weeks. As far as evaluation of patient education, be sure to listen to feedback from patients to see their understanding of the pain relief measures, and also provide materials they can take home to explain to their family and to give them a reminder of what to do at home. Reassessing pain in our patients is very important to determine whether our non-pharmacological pain relief methods have been effective or not. If we find that they have not been effective, we can revisit using other methods or find a method that works best for the patient. Implementation of this plan across all of our PACU units in our organization can take approximately 6 months, beginning with education of our staff through implementation and evaluation. Since pain is subjective, the best method for evaluation and monitor success for non-pharmacological pain relief versus narcotic administration will be patient surveys. Implementing change long-term could help patient success rates as far as post-op pain, discharge teaching, and reduction of adverse reactions from narcotics. This prevention delays discharge, patient falls, and narcotic dependence. And that is the conclusion of this presentation. If you have any questions, please comment below. Thank you very much.